vet jag att det funkar. Är det okej? Då kör vi, jag kickar igång det nu och sen så... För att... Okej. Ja.
Welcome to this online seminar at the Institute for Future Studies. As everyone knows, we live in rapidly changing times. And I think truly we can say that no one knows how the world is going to look in 6 months or a year from now. Humanity seems to find itself in what we could describe as a global and existential shock because of the corona pandemic. Theories, reports, death curves, models, probabilities, risks, and threats are swirling around in the news and social media. My name is Gustaf Arrhenius. I'm a professor of moral and political philosophy and the director of the Institute. With me today I have Johanna Adami, professor of clinical epidemiology and the president of the Sophiahemmet University here in Stockholm. Johanna received her PhD in epidemiology in 1997 from the Karolinska Institute and a Master of Public Health from Harvard University. And she has a diverse background as a doctor, public health scientist, and is currently on the board for WHO Center for Drug Safety. We will start with Johanna giving a presentation entitled How to Handle a Pandemic, What Evidence Do We Have? And that will be for around half an hour. And then there will be a discussion between me and Johanna, and there will also be then an opportunity for you to ask questions. This webinar will be broadcast on the Institute for Future Studies YouTube channel. So, but anyone now watching it can also access the online tool slide.do, sli.do. If you enter that in your browser and fill in the event code 1010, then you can just write your questions and I will get them on my iPad here, and then we will discuss them. So you're very welcome. Moreover, in these times when we all have to go digital, there is a lot of, there might not be enough bandwidth, a lot of stress on the system. So if you lose your internet connection, don't worry, we're also filming this so you can watch it later. But I hope you can be with us for all the time. That's it for me for now, and now, Johanna, the floor is yours. Very welcome to the Institute for Future Studies.
Thank you very much, Gustaf. But I think we first should introduce ourselves to each other. So what about this?
Okay.
I'm very pleased to be here today.
Nice.
And I have some questions for you.
Oh, for me, okay.
So how are you feeling today?
I feel good, I think.
You feel good? Yeah. Fever?
No fever, I promise.
Bad feeling in your body or in
No,
your,
my body feels good.
like that. So how did you get here today?
I actually took the public transportation today.
Okay. So
there was no people on it.
there was no people on it. So you had a distance?
Yeah, distance. I had a whole seat for myself.
Yeah. And have you washed your hands?
Many times today.
Yeah, many times today. And for the 20 seconds?
For 20 seconds.
Yeah.
I shouldn't sing the song I usually sing. But
I just did that, but which might be a good idea as well. This is some, so just we put this before we get started. I do it as well. And the best way, having this is to dry air it. So that's very good. And in case when we talk with this other, I have two, one for you and one for me. If we happen to touch our nose and so.
So, good instruction.
Yes.
Thank you very much.
So now, let's get started. I'm very pleased to be here in front of you all in virtual reality and talk about epidemiology, talk about evidence, and I really hope that we can have a lively discussion in this very, very, very challenging era in history. And to start a little bit with history, this is a map over London in the 1800s. And the dots here are dots where persons died due to very, very severe infectious disease. It was cholera. And Jon Snow, who was a doctor and an epidemiologist. He started to do research. He started to understand why people die due to diarrhea, and this was really a pandemic or epidemic around the world. And here you can see a graph correlated to Broad Street, what happened during the first, when it all started, and then what happened when it went down. And I will soon go into the explanation for this and the intervention that he found was necessary. This is from the newspaper that time. So what Jon Snow found out, it was that this contamination must have come from the water. He found out that there were two main companies providing water to different households in London. Southwark and Vauxhall, Lambert and Waterworks. And he found out that the water from Thamesen came from different parts. So he really then did an epidemiological study, used biostatistics, and then counted the deaths related to where the water came from. Of course, Southwark and Vauxhall was very upset, since he found out that the reason was that the water from Thamesen was not clean. Another famous person, epidemiologist and nurse, is Florence Nightingale. And it's actually the research that she provided related to hygiene, and the thing that me and Gustaf just did, where she performed epidemiological studies among the military or the army during the Crimea War. So she found out the really nursing methods necessary to treat wounds, preventable disease, and other causes. And that made her very, very famous. That made her the first woman to be a member of the Royal College of, or Royal Society of Statistics in UK. And now over to the coronavirus. So let us look at what is the state right now in the world by looking at this map. So right now in the world we have a total of some 205,000 confirmed cases. 82,000 of these have recovered and 8,000 have died. And this is what we know from the reporting system, healthcare system, and so on and so forth. So let me then go over to a little bit more about the coronavirus. This virus was first mentioned actually already in 1968 in the scientific publication Nature. And since then, we have learned a lot about this family of viruses, that it causes a variety of illnesses in animals, and it's very, very common, actually 1/3 of common colds and sometimes respiratory infections is due to the coronavirus. And as I said, it's a family. And in 2019, this novel coronavirus, at the beginning it was called 2009 nCoV, a novel coronavirus, which now has the official name SARS coronavirus 2. This is interesting why it changed name. SARS epidemic a few years ago, that also was a very serious disease. What we know from that period is that it was very, very difficult to be diplomatic to find transparent data and information from China. So China really did not want to have the SARS name for the virus. This was a big discussion in WHO and other parts or organizations. So, however, the official name is now of the virus is SARS coronavirus 2. the disease, the coronavirus disease, is COVID-19. So these two are the official names for the virus and for the disease. And who is then the expert who knows about the coronavirus? It's a number of experts needed that are essential for all of us now to combat this very serious virus and the pandemic. And being myself a healthcare professional, I could say general epidemiologist, I'm not a coronavirus specific expert. Me and my colleagues, we need to collaborate. So you have biostatisticians, biologists, people in intensive care, doctors and nurses, microbiology, public health, epidemiology, and infectious disease experts. And of course, a number of other essential experts. It could be in psychology, sociology, in politics and whatever, or political science, economics, and so on and so forth. But now I relate to the virus and also close to the patient and how to combat the pandemic. So what is then a pandemic? Well, I think it was last week, or if it was the week before, the WHO said now it is a pandemic, because then we could see that it is a disease outbreak and it occurs over a wide geographic area, affects a very high proportion of the population. And the overall goals when combating a pandemic is to minimize mortality disease and to minimize other negative consequences for individuals and society. And I will come back a little bit later what's the tricky parts in especially this overall goal. And this is a figure where we can illustrate the continuum of pandemic phases. So you have the inter-pandemic phase, then you get an alert, you see that something is happening, and now we're in the pandemic phase, and all through all these phases you do risk assessments. Preparedness you need to be, you try to respond to the pandemic, you look at the recovery phase and what is affecting that, and then you have the transition phase and again the inter-pandemic phase. So this is an overview of how a pandemic works, and also in all these phases how we are working around the world now to understand what is the most efficient ways to handle this. And epidemiologists with various expertise in very many different areas, but as an overview, what you do as an epidemiologist in this case is that understand the factor that causes this. In this case, it's corona came up, completely new. We knew something from other coronaviruses, but many things we don't know. And then study who will have the disease or who get the infection. And now also a big discussion talking about what we call in my field subclinical changes. For example, this is that before you get the disease, during the incubation period, can you find out some markers and then also understand if you spread it during that time or if it doesn't matter, and so on and so forth. Also, what we're discussing a lot today is that how does it look in different populations? And can we use data from other countries in the Swedish context? Can we just use what we call in science external validity or generalizability, that what we now know what happened in China, could we just say that let's do as they did in China or in UK or in South Korea or in France and so on and so forth. But that is also where epidemiologists are involved. And what I also will get into a little bit later is that if there is an intervention, if it's prevention by washing your hands, if it's vaccines, if it's there other type of medication, how does that work, and who will benefit to receive those interventions, and so on and so forth. And digging a little bit deeper now, talking about who is the expert. And infectious disease epidemiology is a whole area of very, very skilled people. It's a whole research area and also a clinical area where you need to be the expert on the methodology, epidemiology, the relationship between a host, which is the human beings, and the infectious agents, the coronavirus. How it's spread, is transmitted, and how can you predict and use special models for that. So we also, all of us want to look into the future now. And of course, the longer the pandemic is spread, the more knowledge we gain, and the more knowledge we can also then have in our scientific work. And factors then that can impact transmission and spread, it's like you need to understand how common, like the prevalence of the agent in the population, how does it transmit, how long is the infection going to last, who are most susceptible for the transmissibility, vulnerable people, how does it look like in a country, how is the population density affecting this, and how do we behave in our society, the living conditions, climate, and so on and so forth. So all this is typical for the infectious disease epidemiologists when they contribute together with other experts. And then everyone wonders, how do I know whether it is coronavirus, the common cold, or if I have the flu? That's very difficult, especially now when they tell all of us here in Sweden, stay home if you have symptoms from that could be like cold. But maybe to make it a little bit easier, since I guess all of us discuss this with each other, and I get phone calls, and do you think is this and that? I'm also responsible for a lot of staff and students at Sophiahemmet. But looking quickly at this, so for example, that if you look at dry cough and fever, if you don't have that, any of that, here you can see it's very frequent in both corona and flu, then, but if you have nothing of that, it's most probably, it's just a common cold. But it is tricky. Of course, and in this state of this pandemic, we should be extra careful for obvious reasons. And also talk about evidence-based prevention. So all these advices now that I want all citizens to really be adhere to, compliant with, they are evidence-based. There's science behind that soap and water is the very best thing to avoid infection. If you don't have soap and water, then having steroids on your hands might be at least a little bit better. But the best is to have both. And also how to avoid contact, and when you travel on public transportation, you should either avoid it or do as Gustaf did, be in an empty wagon, and work from home, social activities, and so on and so forth. These are evidence-based. It's science behind these advices. Then we also talk about who is at risk. The elderly, the vulnerable people, if you have a weakened immune system. And I put a question mark here. Well, of course we cannot say, is it 70? So what about if you're 69 or 75? But that's a good idea. So 70, we have said. Is also, we don't know from the scientific evidence whether pregnant women are at a greater risk or not but then let's say it's better to also protect them. This is one of the papers that came out in New England Journal of Medicine quite recently, where they have looked at some of these factors, clinical characteristics of coronavirus disease in China. So these are the type of scientific evidence then used for the guidelines and recommendations for us as citizens or public or in the healthcare system. This is also what we know or don't know as of today. That how is it spread? Well, it is a new illness, so we don't know exactly, but we know more and more every day that goes, how it spreads from person to person. And we know that similar viruses are spread in cough droplets. So compare with the flu that spreads in the air. In this case, you need to be in contact with someone who has the virus in certain levels and get some kind of droplet from that person. Otherwise, it doesn't seem that it's spread. And it seems extremely unlikely that packages and food, I've seen many questions, what about if I order something from China, it went all over here, and I go to the post office? Don't worry, I would say. And the treatment, there is no current treatment. So the treatment we use in healthcare is to relieve the symptoms, or you can relieve the symptoms when you're home and having some paracetamol or something like that. If you have corona, you need to stay in isolation, away from other people until you have recovered. And the recommendations here, as of today, is that stay home 2 days after you have recovered, then go back to normal. Those are the advice that I give to my staff and students, and those we use in the healthcare for those also treating patients. So, the million-dollar question now is that can we find a treatment? Can we find that could be medicines or it could be vaccines? In order to find that, we need to collaborate, as in all other types of treatments that are for other diseases. So if you want to find preventive treatment or care, diagnostics, you need to use the relevant researchers in the field. You also need to collaborate with companies, with the industry, as well as with society. And just to give you an overview of the phases that you go through in any clinical trial. And these are the international and ethical approved guidelines that in order to get anything approved from an authority, you have to show your data and your results before the FDA in the US or our regulatory agency are allowed to approve it. And normally, you do lab studies for several years, human safety studies, expanded safety, before you then test it on thousands and thousands of people. So these are processes that usually take many, many, many years. Now there is a rapid assessment group at WHO and elsewhere where that are now working to shorten this period. Also looking at what we do as a researcher when you have a vaccine trial process is that it's so important that to do what we call the preclinical studies when you're in the laboratory with animals, you have to understand if it works, and you also then need to understand, is this safe, and how is the immune response and so on and so forth, which dose is the best, and is that safe, and who again benefit for a vaccine, because we don't want to get into any type of state when we do experiments unnecessarily on human beings. Actually, the legislation, the international legislation behind this was founded after the Second World War for obvious reasons, and it's called the Helsinki Declaration. So it's complicated, that's the bottom line. So, who are involved in our countries? Why does it take so long? Why do we have so different opinions? Why do we handle this differently between countries? Again, as an overview with a blue part here is that we want to help the patients or the persons. And in order to do that, and talking again about the need for collaboration, which is essential, you need to involve the industry, the research institutions, you have the healthcare system, you have the payers or fiscal intermediaries, you have all the authorities. And then you have politics. And that, we all know, differs between our countries. So it's an ecosystem that we need to understand why we have built that system, and also how decisions can be made and why they are made differently. So, because there is a trade-off between interests, of course. It can be jurisprudence, medicine, healthcare, ethics, philosophy, politics, and the values and varying approaches. It could be integrity and self-determination, conception of life in a society, health, quality of life, economy. So where should the balance be? Should we be hard regulating, punishing people who do not follow their recommendation? And what is also this about integrity and self-determination? So these are values. And how the authorities are handling this right now in the world is actually based on a legislation. International Health Regulation formed in 2005 that all member countries in WHO have to follow. And we have a Swedish law relating to this from 2006. So there is a law behind this. So, and in this paper, quite long paper, as of 12th of February, operational planning guidelines to support country preparedness and response. This was written after a 2-day meeting with 400 experts all over the world that were at WHO, and those were some of the experts that I showed in one of the first slides. Also experts in ethics, experts such as in logistics. What if we find a treatment, a vaccine? How should the logistics be? Do we have storage shelves to a certain amount? How do we do with the shipping and all that stuff? So it's a very, very complicated or complex, I would say, and all that is needed. And then going to our authority in Sweden, they also have then a document how to handle a pandemic. And I think it's interesting if any one of you after this seminar want to have a look. It's public, of course, but you can see that in this document also ethics are discussed, financing, legislation, and so on and so forth. But this is when we see the authorities now in media. This is the scheme they are following according to the figure I showed earlier. So flatten the curve or lockdown. This is the flatten the curve picture that I think this also, you can see this on Facebook and in the papers and so on. This is like the strategy right now in order to not put too much burden on the healthcare system at once to be able to handle it. And then what about lockdown? Yeah, what is lockdown? Well, lockdown can be like you have a certain geographic area that is locked down, or you can have non-mandatory recommendations to stay home. You can close certain businesses, the restaurants, and so on and so forth. You can ban events, such as now in Sweden, no more than 500 people. What if you're 499? Is that okay? But you know so that's a choice made on some of the previous and current knowledge what might be efficient. But you need also, of course, then follow and do the risk assessment throughout these types of interventions. This is an article, and there are several articles, but this is, for example, cost-effective length and timing of school closure during an influenza pandemic depend on the severity. So this is also what researchers do to evaluate what are efficient interventions or not. Another example was the Ebola crisis some years ago, an extremely severe disease where you both had good and bad examples, for example, of lockdown. In one particular area, it became a riot when they locked down. And in another area, when they included more of the society, there were anthropologists involved, the church and so on and so forth, and the key opinion leaders were involved, there it was successful. So there are many, many factors that we need to take it into consideration if you're going to use these interventions to combat a disease like this, to minimize transmission. So I'm going towards the end. I'm sure you intelligent people know this word. Gustaf knew it. I don't know if you Googled it before. I didn't know it. But Gustaf called me last Friday, the 13th. This word that I cannot pronounce, fear of Friday the 13th. And as an anecdote, it was a physician, Dr. Donna Dossey. He told his patients, he was in psychiatry, that when you learn to pronounce it, you're cured. But this leads us into our discussion then, who should you believe? And what is our responsibility as scientists with all this information that's coming from various parts, in social media, in media, but also in the science? I think this one is quite illustrative from the International Federation of Library Association and Institutions. And how do we do as researchers? Are we critical where information is coming from, the source? Do we check the author? Is it a joke? When was it published? What does the expert say? And which of the experts should I believe in? And if you're interested to look at the scientific evidence about corona, the corona disease, you can easily go into the WHO database. It's open, and I looked it up yesterday, and I stopped counting after 700 of scientific publications in various areas as of up to date. And that is the source, I believe, as a scientist, is the most interesting to understand what we know and what we don't know. So, will we survive? Well, this is just to illustrate other, as I say, death toll, that in the 1300s you had a Black Death, 200 million of deaths, smallpox, Spanish flu, and HIV, 25 to 35 million. And here we have the novel coronavirus as of March 15. I of course not have no one of us have the answer that will we survive, but I'm very how should I say, I'm optimistic in one way, here in Sweden, the healthcare system and everything we have, but you should be very, very, and all of us are very concerned about how this affects the whole world in various ways, and with other aspects and than our health. So this is, I will end with an information video from the Vietnamese Health Department. And thank you for listening, and I look forward to the discussion.
Thank you very much. Thank you very much. That was great. And I would like to remind you that you can ask questions by going into this slide.do, and the code is 1010. And we've got lots of questions. I will pick some of them and put them together. I thought we could start a little bit soft here, but you were talking about that. What is an epidemiologist, and what is your profession as compared to other people? And the difference between you have virologists and you have epidemiologists, but you have also different kind of epidemiologists. And as I understand it, you work as an epidemiologist. You have to work very interdisciplinary. So you are an epidemiologist. What kind of epidemiologist are you?
I'm a clinical epidemiologist.
What's that?
What's that? So the research I'm involved in is very close to the patients. So my expertise, so to say, is actually to evaluate treatments and the effect of treatments, new treatments, both evaluated from a health point of view, but also from a health economic point of view. In summary.
So you think about it. So if you take for example, the Swedish Public Health Agency, that have been under a lot of pressure during this time because people have different opinions. So they of course have epidemiologists.
Yes.
But they also, so far I can see, they also work with mathematicians. Do they also have people in other fields?
Absolutely. I mean, that's essential for them. So as I described that at WHO, with the 400 experts that were now emergently formed a group when this all started. And that is the same with our authority here, that it's essential that you have the microbiologists, the virologists, the physicians, the nurses, everyone involved, as I showed in one of the early pictures. And the economists and the mathematicians, statisticians,
and even people doing ethics, as we saw.
Yes.
But then we can see, and maybe have a debate about this, and some people say, okay, the Swedish Public Health Agency, they are wrong, they should do this. Then there's often somebody written from one science person, maybe a virologist, or maybe even someone from a person in psychoanalytics, that, well, they might not then draw on this kind of broad thing that they draw on at the Public Health Agency, but they have a whole group.
Yeah.
So is that a little bit of a problem, like with the, if you have a hammer, everything looks like a nail, and then you think, yeah, you have to hit it with that.
Yeah, I've thought of this a lot, and that was actually when you first asked me, I was a little bit reluctant myself to come in because I am not a corona expert, so I don't have any claims. But we also, again, going back to society, to media and ourselves, that it could well be so that a person with one of the expertises related to corona are completely right in those statements, but the authority have the whole umbrella. So that also depends on how you communicate and what you say, and also how is that transferred into when it becomes something in media. So I wouldn't say that people are wrong in what they are saying, but as a scientist, it should be easier for us to also put it into a context, because you were talking about from your dimension and from your expertise. And that is of course also very complicated and troublesome for lay people, and so to how where to find that.
But for me, it seems actually, I mean, this is a interdisciplinary thing. So it's actually, you should, as a scientist, if you go from your own perspective, you should be a bit careful because you see one part of the problem and not the whole part of the problem.
I agree with it. And I think one interesting thing when our public health agency started and to inform the public and the healthcare, actually they have only changed the advice once, how we should behave. The first advice was that they were more specific on which symptoms, then it was 38 degrees fever, and if you had symptoms from your lungs, then they said call 1177. And then they changed that last week when we need to be more careful and say that if you have symptoms that could be like common flu, be careful. So if you really analyze what the Public Health Agency had said, and they have been very, very consequent in that, there are two things. But then others say several things that might not be wrong, but it blur it up. But if you trust the authorities and look how they have been actually quite consequent in what they...
To be specific, that's what they said on their homepage, but maybe they said more things during press conferences and things like that.
but maybe, they also should be able to answer questions and be transparent, more specific questions, but then they have not changed their documents or their advices to people in healthcare or the public.
But then to sum up this, so they do have done a lot of other fields there. I mean, behavioral science, I understand from your perspective, that's going to be very important.
It's extremely
So
important.
they have access to really good behavioral scientists too, and they try to... So that's very good. Now, a question that comes, and this comes a lot, I can see here from you, the audience, and it's connected to this. I mean, so we have this Swedish Public Health Authority. Of course, they have all the scientists, and they're also in touch with WHO and with the similar authorities in Denmark and Norway and UK. So they see a lot of information.
Yes.
But then the natural question that comes up a lot is, why do we do different in different countries? Why are the responsibilities? And that makes a lot of people think that's very strange.
Yes.
Why don't we do like South Korea?
Yeah.
Why are we doing this? We're doing wrong. South Korea did it the right way.
But as a scientist and you're a philosopher, you can change that. Why should we do like they do?
That's my question.
Why should I? So I see if there are any of the previous slides that I can go back to. Maybe, actually maybe.
That was one slide that was important, perhaps.
What?
Is that one? Yeah, here you go.
I think this one. Why do we do differently? If we also, when I describe what's the expertise of an infectious disease epidemiologist, is that, for example, a virus can be very different in different geographical areas. A virus, as any other disease, might act very differently in different populations due to genetics, due to the environment, due to the seasonal weather.
Age, perhaps also, how does it
age and as a population density. So that's again that first now when we have all this, and most of the scientific reports for obvious reasons now come from China, first you need to understand, is this study of high validity that they explain, and internal validity, and then the next question is, what about the external validity or generalizability? Can these data be transferred to another country? And then, as I had a picture, what type of system, what type of values?
So that's the next one, I think. Yeah.
Maybe it is, or you mean maybe
that
this
one? I thought was important
yes.
also.
And how do we value life? How do we value integrity? How do we value the politicians? What happens with autonomy and stuff like that? So those are also factors that need to be taken into consideration. You have to tailor it according to a number of factors that also goes into behavioral science, anthropology, psychology, and so on and so forth.
So
So it's like one size fits all is not the thing in this
Okay.
case.
So take a concrete example, for example, if we're going to discuss this more, but if we take lockdown, if we take China as an example of lockdown, it's not clear that we can do the same thing with the same efficiency here in Sweden. You would say?
I mean, I ask you, if you were forced to be locked in here in Sweden, and you feel hungry in the evening or want to go to the shop, I mean, I guess you from your self-determination would do that. But if you have a country when you get punished or locked in or put in jail or whatever, then it works. It might be extremely efficient, but then we go into areas where I'm not an expert in, but then we go into what is democracy and what is...
But that's the problem, that you have to think about, I mean, you might not be able to use the same kind of lockdown strategy because of different cultural relation and also different ideas about how democracy might want to be more democratic, respect people's autonomy more. And that's also an explanation. How much can the explanation also be part of that? I mean, in Sweden we have rather independent public authorities, and in other countries we don't have, so they leave more for the government or the politicians to decide. Is that also very simple, very even between so similar countries as Sweden and Denmark or Sweden and Norway?
Yes, I mean that we could read in the papers that the public health agency in Denmark, he actually went down public and said was not my advice, it was the politicians. So that is part of it. As a citizen and as or actually also as a researcher, I have thought of this a lot. When if people wanted to have our politicians to override the authorities to a greater extent, would we as scientists want the politicians to decide who gives us the research money from the research council?
No.
Would we? I mean, if we talk about this also in a more, for me, it's a very lay person philosophical way, is that if we, in this case, said, oh, they should do something, they should do what they do in other, we also might is that what we want? So we have another model. But then, of course, if our politicians didn't have trust in the agencies, then of course Stefan Löfven could also say, I don't care about that. We decide. Of course they have that possibility. But I think we should be actually proud that we have built up this system. So it's very, very shaky, I would say, if we now say why they should decide more.
I mean, I should point out the ultimate responsibility in the end is the government. So they will have to take blame if things go bad, even with this independent plan. Now, so let's go to this that's been discussed so much. It's sometimes called lockdown and flattening curve, sometimes mitigation or suppression. And for me, it's not completely easy to understand. I mean, for example, it seems that lockdown or certain kind of lockdowns can be used for mitigation or for flattening the curve. So is this just two extremes on the spectrum? So you can have actually lots of different policies where you have okay, we all want this kind of suppression. The question is how much we want to suppress it, and that you can get with different kind of means. And is this suppression necessarily connected to the idea of herd immunity, which we might have to explain?
Yeah. So now there were many questions in one. So, but if we can reason a little bit about this lockdown and, as you said, suppressions versus mitigation. It also, and it was this recent paper, I think it was Imperial College, that published it. One must also see that they were modeling the proposed efficiency, but they also speculated about the challenges with complete suppression, and that goes back to our previous reasoning that can you just do it? What is the cost for having suppression? And because now it's mitigation. I mean that we're into like flatten the
and that's the policy in Sweden. You would say that's also the policy in France still. It's a kind of
it seems that is why
they just feel that they have to take a bit more harsh measures at this point.
Yeah, it could be so. And then we have this like herd immunity, and also the discussion whether that is a strategy for herd immunity, and also for people are relating to Great Britain and so on and so forth. I mean, if that was a strategy from the beginning, then we wouldn't have done anything at all, which we actually have done in the pandemic handling of this. But now we're in the state that it's become. When we got more knowledge and understood how this virus, again, we must remember this is a new virus. We don't know how it's behaving to such extent as we do with the flu and so. So therefore now we know it's going to be that is spread in society, but we still then know that how can we protect and minimize those who get severe disease or even die. We have to protect them, and we all as members of the society have now a responsibility to contribute to that.
So I think that some people interpreted the strategy in UK and to some extent Sweden for a while, maybe incorrectly, that the idea was to get herd immunity but not to overload the healthcare system. And that's why you went for flattening the curve.
Yes, and maybe it's semantic or a misunderstanding when you debate that when people say that we go for a strategy for complete herd immunity. Is that meaning that we just let it go and then we will be over it? Some people will die. We don't care because it's more important for the overall health. But we still say here that now most of us perhaps will be infected, but we also put in resources to minimize the really fatal cases due to this.
Yeah, so in connection with this, a question that comes from one of the viewers. What do we now know about immunity? I mean, is this, as you said, a new one? And for some viruses, you get it and then you're immune for a very long time. For others, the influenza is a bit trickier because it varies so much. So every early fall we have to check what happens, and then maybe we can construct a vaccine that will work somewhat well. What do we know now about the corona when it comes to immunity?
We don't know. But what most people think is that if you, let's say you had it last week, that most probably the probability of having it next week is very low. So hopefully, or most probable, is that you will not get it this season. There are even people now who are in the scientific world who are discussing, could this even be a virus that we never ever will see again?
Ah, so it's very stable then. So that,
could it be like that? But that's the tricky thing in talking about experts. Those experts in virology and all the laboratory science that are going on right now is to understand, is this a virus that changes a lot or often? Or is it even a virus that you can find a vaccine for a long time? Or is it a virus that this was a pandemic and we will never see it again? That we don't know.
No. There was something coming out that seemed a bit, from virologists, it seemed to be a rather stable virus, but that's the first
And again,
not
then,
peer-reviewed study.
And then, so that goes back to, one study. Do you believe in your field? That study, now we have like Save the World. You need to also, that's also science, is it repeatability in others? So, but yes.
But to stay a little bit of this, to understand this, going back to this suppression or lockdown, and as you know, Remivita is what is done in China and South Korea. What can we out understand that? I mean, how long do they have to be in lockdown, and what happens when they stop being in lockdown? Can they just be in lockdown, then they can stamp out the virus, and then they can go back to completely normal? But then what happens if the virus is around in other countries? So
then
how should we? Do we know this? Does China know? Does South Korea know this?
That's $1 million question. And I mean, I can say myself, and we are all affected now. Let's say the lockdown of universities. I'm head of a university with 1,300 students, and when I closed down and we went digital Monday afternoon, I mean, I cannot tell when we're opening up again. And that's again, that goes back to this is a new virus.
So
But I think scientists agree on that a lockdown for a week. I mean, then it was just that period and then it peaked again. That's too short. But that's going back to this.
We got stuck there.
Go stuck. So if we can get this away, and I reset. But going back to yes, no. I want to show this slide again. See if it comes up.
Yeah.
Now it became very dark.
Just press again. Yeah.
I'm soon there. Going back to this picture, or this figure, we're now in the pandemic phase, and as you see this line across all phases, the risk assessment. So what we do now, and which is so important now, we made an intervention, we say lockdown, and now we need to follow the graphs to see how the transmission is affected. Then in a few weeks it will hopefully be more easy to propose what to do in the future. But today I wouldn't dare to say a long time.
And the same for South Korea and China. They actually don't really know now when they can. What will happen if they let go a little bit of the lockdown?
But Wuhan, I mean, they're very, very effective with their lockdown. They have started to open up and go back to a little bit of normal. So but that might be also a shaky thing. Who knows?
So we'll see that. Good. Let me see now on the more questions here. Yeah. Yes, so there's a question that's been coming up here from the viewers. What's the likely end game? Is the vaccine will appear after 18 months, or and we need to just kind of wait for that and keep on with this kind of flattening the curve, sort of this thing, and even lockdowns? Do you have any idea about this?
No, but also again referring to the experts, and I go now to a vaccine trial process. First to explain, and as you mentioned when you were introducing me, and being myself involved in some of the WHO work, I mean there are so many efforts now done to have this rapid assessment in order to make approval to test various kinds of medicines. A few weeks ago, 200 trials had been completed using already existing vaccines and medication, but none of them seem to be working. So I haven't answered your question, but the most common opinion in the scientific world is say that maybe within a year or maybe 18 months. That's the time, and why I'm showing this as opposed to several years.
Still a long time.
That's still a long time. So that also goes back to that this flatten the curve. Saying me now I'm saying 18 months. I'm not saying that means that the virus will be around for 18 months. I don't know. But if anything, we're talking those numbers of months or year. There might be coming in medication, but nobody knows.
So let me follow up that also. I mean, as I said, we talked about this a bit hard to say, but there's so very different structures in different countries, but they all try to contain this. But isn't there a problem if countries follow very different strategies? If some go for more aggressive kind of lockdown style, and some go for more like a mitigation, then you will have to keep very, so say, no movement between these countries. So isn't there?
It depends on. I would say it depends on from which aspect you are looking at it. From an epidemiological aspect or health health aspect, that might not be a problem, but you are more experts in the audience in other fields for economy,
Right.
for the GDP. Of course, when we see this very, very severe economic impact in the world, that will cause poverty. That will cause debts
Definitely.
due to how we're handling the coronavirus. But it's not completely obvious to me that that is a problem related to the transmission.
Here's a question again from the audience that didn't come up in your presentation. This question: the technology that you need to treat the kind of severe cases, is it very expensive and advanced, and that's why you don't have it in certain hospitals? Or, I mean, we know that there are certain reasons why we don't have it, because at least in Sweden we decided to keep less of it, but that's no decision. But it is can't one just very quickly build up this capacity?
Yes, you can, and that is also that it's been heavily discussed in media and elsewhere during the last days, and I'm also heavily involved since Sophiahemmet. We have a hospital as well. So yes, that equipment is expensive. If you are, that's why I put this in, if you need intensive care, being in a respirator. But that also goes now back to what preventive measures or what preventive actions can we do? If we avoid ourselves to spread the virus, and especially protect those who we evidently know are most vulnerable, those over 70 or 80, those with chronic diseases or other vulnerable states, if they do not get ill, because there are those who are in need of the very severe and expensive treatment, then the strategy now is the only way to try to keep it that. We know, at least from the China data, and the first picture or graph I showed, I mean, most of us will recover. Especially you and I, Gustaf, who are in a very young age group.
Thank you very much.
if we definitely so. We'll get it, we'll recover, and then go back to work or whatever you do. I am, from a Swedish healthcare perspective as of today, and also of course very much involved in also the healthcare sector, not worried, but we now need to, and what we do now every day in Sweden, also allocate the resources and the competence to the right medical wards.
But again, I mean, so is this equipment very costly and hard to?
It's not. I wouldn't say it's not the equipment itself is not the hard part now. It's like the number of beds that might be needed, because you need a facility. But there are also, I showed one plan from the public agency authority. There are other plans that are also open that we now, and as of today now, the National Board of Health and Welfare will now also take the responsibility to guarantee equipment of various kinds. So
and can we quickly get more beds, or why not?
I mean, we can. I mean, if you can combat war in low-income countries, and we can help each other, those are solvable problems. They're not easily solvable, but they are solvable. I would say.
And connecting this, and this is a question that also came from the audience, and it connects. I mean, how much do you need to suppress or mitigate or flatten the curve, not to overload the Swedish system? How many cases can we have at the same time? And is this must be extremely hard to say, okay, we need to do this and this to keep the number of intensive care unit patients on this level. Is that actually what we're trying to do?
Yeah, I mean, yes, and that, if we go back to the Chinese numbers, I mean, like, there's a big cohort of some 80,000 now that have the disease. Now we can also see that what percentage of that cohort was severely ill, and what percentage, a few percent, that needed like advanced healthcare. So if we, I mean, those are the numbers, trying now again to give the best guesstimates and modeling the need for healthcare. So I wouldn't really dare to say the number, otherwise I will be cited now and the so-called corona expert. So, but there are not so very many. I mean, I would say, looking at the numbers and the chart that Johns Hopkins University have this in real time updating data, I mean, there's a huge underestimating, of course, of all the, because everyone has not been tested, and we don't test everyone here either. So, yeah, that was definitely not the clear answer that you wanted, but that's basically, I don't know. But
I'll continue a little bit more on this, because I mean, what happened in Italy, in northern Italy, there seemed to be a shortage of equipment and personnel.
Yes.
So they didn't.
No.
And why couldn't they get much more equipment and personnel quickly?
Yeah. That's again also interesting when comparing countries, because going back, being an epidemiologist again, and looking back how the first case was relieved, and their healthcare system, their population, and so on and so forth, it went many weeks there, and had a huge spread before they understood that it was very serious. And I think it's also important, because people also tend to want to discuss this related to other healthcare challenges in Sweden, about management, and so we should also, all of us, remember that Sweden is among the countries with the most doctors and nurses in the world. We're number 4 on that list, relating to other OECD countries. So we have many very skilled persons. For example, these nurses have always, over ages and hundreds of years, been the most important health professional in combating infectious diseases. So that is, and moreover, we actually have one of the best high quality healthcare systems in the world.
When Northern Italy, they're very rich, they must have had a very good healthcare system.
Some of them are rich. I'm not saying that they have a bad healthcare system, but also going back, talking about politics, independence, autonomy, and it's a country with other types of infrastructure, and that was very evident that it had gone so far before they started their interventions.
So you mentioned this with testing, and there's been lots of discussion about that. We now only test people in the hospitals, and a lot of people have asked also here, why don't we test more, and what's the problem? Why don't we have more tests and just test more massively, like they've done in some countries?
So then I make the question, why should we? What should we? So thinking, what would we gain with that? Well, nothing.
Okay, so the idea, I guess, the layman's idea would be that if you test, and you say, okay, you should go into isolation.
Yes, but that is also what we know now fairly well, is that who benefit from isolation and can recover and then go back to work is the person that really follow the advice from the public health agency or authority, that if you have symptoms, mild symptoms, then you should consider to stay home, or actually stay home. But doing mass testing, it costs a lot of money. It takes the resources from those who really need now to treat the patients. And that, an analog, I would say that, I mean, with all the technique and knowledge we have today, you and I, we can go and buy a genetic test on the internet, but what do we do with the result? And the analog is that, what if you, without symptoms, neither of us know, we maybe have the virus inside of us. What would we do with that test? It costs money and resources, but no one would treat us. And now we know, talking about herd immunity, So that is deemed to happen. So why do it? But people love to say that what if we had done as they did in South Korea, then we would have been in another state right now. I don't think anyone can answer that question, whether that would be.
So it's not because of a shortage of tests, because of it would take a lot of time and money and not be
No,
a question.
there is now also a shortage of tests around the world, but that was not the basis for making a more focused, to define more focused groups who would benefit from testing because they might need a treatment.
Good. We have some more questions coming from. This is a question that comes back. You've been touching upon it earlier. What's going to happen in the more close future, the summer and the fall? There's some discussion. Well, usually if the summer comes, then it will be less of a spread, but then it will come back in the fall again. Do you have any idea whether that's the situation?
Actually, this is about seasonality that relates to some viruses. As far as my understanding goes today, we have actually no clear evidence from science that this is the same with this virus. Well, looking at the maps now, we see that in the southern parts of the world is less cases. But if that has to do with the virus or other things, I'm not sure, and I want to be careful in answering. So therefore, that is something we don't know, but we can hope. But that is also what is discussed: is the disease now and goes up and will come back? And I think the responsible persons from the authorities have been speculating about that. But they have also been clear that they are speculating or doing the best guesstimate we can do.
But maybe we'll stick to that a little bit. I mean, it could go. We don't know whether it's a kind of a seasonal one, but we do know, or do we know that it actually, with no certain extent, that it's in different countries that are very similar. There seem to be more cases and less cases. Do we know? I mean, testing of course is very imperfect, but it looks like per capita Norway and Denmark have much more cases, double the cases we have. You can also, I guess, and that's a question for you, calculate a little bit backwards from the number of deaths, or from the number of how many cases should you expect it to be. And is Norway and Denmark doing worse than us there too on per capita? I'm not so sure about.
Was your question if the mortality, because the mortality still is very low, but we have
per capita they have more cases.
Yes.
When it comes to people diagnosed.
Yeah, diagnosed. Yes.
Yeah. And then you wonder, okay, is it then likely to be that they actually have more cases per capita in Norway and Denmark than in Sweden?
No, I think that's now being more going into statistics and see if there are significant differences, and also relating to. I don't think anyone can answer that. And also again, I'm not do not completely know about the Norway. I mean how the cases come, but we definitely know here in Sweden, especially in the Stockholm region, that it went up after people being in Alps.
The sports strike.
Sports strike. And then I'm not sure if that was all. Well, I know that in Norway it was a physician, I think, that were actually one of the super spreaders, as you said, not by meaning, but that is something we have seen with this virus, that are few people that when they have the infection and symptoms, that spread it to hundreds of others.
But so there we can't be sure.
No,
What about that it seems to have spread much less in Africa, for example?
Yeah, and so some speculations that it doesn't like warm weather, but I'm not sure. And from the scientific evidence, I don't think anyone dare to say that that's due to warmer weather and the viruses doesn't like to be in warm weather. I mean, such as the flu. Some people want to compare with. So I think it's too early to say, because you also can see in some of the African countries, for example, and in Thailand and Indonesia and so on and so forth, But we also, don't know about the reporting systems. Iran, we know it was very unstable numbers. And
But very high numbers.
there were high numbers,
Mm.
yes. Any countries that is now reporting, we don't know how many are diagnosed or taking the tests.
Mm.
But you also do, as we do now in Sweden, clinical testing. If you have pneumonia, for example.
And what about this, that calculating backwards from the number of cases you have of people dying from it? Then you can do a kind of estimate how many
Yeah.
cases you
Yes,
likely to
and
have.
that is, and also then relating to the demography, demography in there. So then going back to your previous questions about do we have resources in personnel and facilities and premises and ventilators, if we come up to that percentage in Sweden who will need severe care. That is again what we now need to monitoring very, very, very carefully if the new interventions, closing down or lockdown in universities, for example, if that will have an effect.
Do you have any idea why we got this very big outbreak? Oh, I see now, I have to say something else.
Yeah.
But Johanna is so, people want to talk to her, so we're going to do something unusual. She's going to go on the Swedish public radio for a 10-minute interview. And this means that we are actually taking a little break. We're going to start again, I hope, in 15 minutes. So that is at Swedish time 5:30. So you can think about new questions to send in on the side. And Johanna promised to come back
So
after
see you.
speaking to the Swedish radio.
And don't forget to wash your hands after the break. So see you later.
Thank you.